Good morning, and welcome to today's interview that we're having in recognition of World Breast Cancer Research Day on August 18th. This day is an annual recognition of the life changing research, past, present, and future, to end breast cancer and improve the lives of those who are impacted by it. I'm joined today by Dr. Connie Visovsky, who is here to tell us about some of her recent work in breast cancer research. Connie, it's always great to have you on the show.
Thank you so much for inviting me. It's wonderful to be talking about this topic. It's so pertinent and so affects so many women worldwide.
Absolutely. So, to start off, would you like to introduce yourself and tell us what your research in breast cancer has focused on throughout your career?
Sure. So, as you said, I'm Connie Visovsky. I've been a nurse researcher for over 20 years and also a nurse practitioner and specializing in breast care. And so, my focus has always been on the neuromuscular effects of chemotherapy for women who are undergoing breast cancer treatment, specifically chemotherapy-induced peripheral neuropathy. And I came upon this topic when I started to see patients in the beginning before they got treated, and then as they progressed through treatment and finished treatment, I started to see the impacts of cancer treatment on quality of life, on being able to do your activities of daily living, particularly physical functioning. Everything from fatigue to neuropathy to muscle weakness, all kinds of problems, emotional functioning. So, when you have physical impairments, you often feel depressed and anxious. And so that also drew me to this topic. And what I realized is while for years some of these symptoms were dismissed as being, oh, these will go away, we find that there's a significant subset of women for whom these symptoms are persistent. And so, especially the persistent neuropathy, which, affects both nerves and muscles, has always been my focus of my research.
Amazing. You have had such an illustrious career of research. So going back to the beginning a little bit, why did you decide to become a breast cancer researcher, and what kind of continues your passion for it today?
Well, I became a breast cancer researcher once I started to work closely with women who have breast cancer. And as a woman, of course, that's very relatable, some of the struggles the women had. First of all, when women lose their hair, it's extremely emotionally disturbing to women. Um, the kinds of body image disturbance, with the focus that we have on women's bodies and sexuality and so on, the loss of a breast or both breasts are certainly significantly impactful. So, as a woman, I really identified with those things. But I also saw, as a nurse practitioner, seeing women day to day struggle with breast cancer and breast cancer treatments and the sequelae of that. Persistent symptoms, as I mentioned, financial toxicity. So, in other words, treatments at the time as they emerge are very expensive, even if you have good insurance. And maybe over time, the prices go down, but initially they're very, very expensive. Fear of recurrence. Women live with the daily fear, even if I'm cured, I come back. Am I going to find I have a recurrence? We hear the term in medical circles called scanxiety. So anxiety whenever you're going to have a scan to determine, if you're still in remission. So all of those things really touched my heart and really had me focus on breast cancer as a topic of research.
That's wonderful and such important work to be doing. And going into some of your recent work, I know you recently had a publication in Seminars in Oncology Nursing about falls related to CIPN, or chemotherapy-induced peripheral neuropathy. So for background, what are some of the challenges and concerns surrounding fall risk with CIPN and breast cancer?
Well, I think one of the challenges we face is that the idea of falls and mobility impairment is not commonly or typically discussed in the clinical setting as we give women neurotoxic chemotherapy. So, chemotherapy is like the taxanes that affect your nerves and your muscles. And when I say the taxanes, for those people who may not know, I'm talking about paclitaxel, docetaxel, and so on. And these few studies that have examined falls in the population related to chemotherapy, their assessments have not been very, very thorough. In our work, we had done a very, very sophisticated gait analysis using a gait right mat that has embedded sensors, and that sensors were placed on the woman's body so that we can see through the computerized algorithm, we can see the movement of the hip, the knees, the ankles, so on, as they go through and the foot as you go through the gait process. And so that's some of the challenges. Some of the concerns I have is that falls are really a source of disability and injury, sometimes significantly so. For instance, if you fall, especially in older age, and fracture your hip, a hip fracture has a 50% mortality rate. So you can have a high risk of dying from that. And so can cause really serious injury. And even if you don't die, you have significant rehabilitation, surgery, and so on. So this really has an impact on the healthcare system and on the individual. So that's why I was so interested in falls and the background of why I thought falls was an important item to discover and explore in our research.
Absolutely. Like you mentioned, such an overlooked issue, but so important to investigate.
For sure.
So what did this study investigate and what did it find?
So I'll have to give you a little bit of background about the study. So this is I'm reporting to you today on findings from the Be Happy study, which is the home-based physical activity intervention for women with chemotherapy-induced peripheral neuropathy. This was a 16-week randomized clinical trial funded by the National Cancer Institute. So I'm very grateful for the Institute for funding this. And we looked at women with breast cancer who received either paclitaxel or docetaxel, and they had to be 6 months out of chemotherapy. And they were randomized to a control group who received educational information or an intervention group who received gait, balance, and muscle strengthening exercises over the course of 16 weeks. We measured neuropathy symptoms, quality of life, gait, balance, muscle strength, and nerve conduction. So, in the seminars in oncology nursing article, what we did was we reported on the baseline or the characteristics of the women coming into the study before anything was ever done, the 62 women who were assigned to the control group alone. And we looked at what would, in a population that didn't have any kind of intervention, like an exercise program, anything like that, what would contribute to fall or what would predict their risk of falling over time? And we used a sophisticated statistical model to look at these predictors and to see if any of the demographic factors like age, BMI, race, marital status, income, education, whether they were employed or not, or the medical data like your breast cancer stage, your estrogen and progesterone status, the number of cycles of taxanes that you had, and if you had a fall within the last month or the number of near falls within the last month. So our findings showed that only the number of near falls in the last month and ankle plantar flexion. So that's the ability of your ankle to point downwards. So those two factors were the only significant predictors of having a future actual fall. So even if you fell in the last month, that didn't predict it as much as having near falls. And in this population, we saw 4 women actually had a fall and 11 women had a near fall. So those women who had a near fall had a higher risk of having a fall in the future. Most studies look at falls, if they look at falls at all, which is not commonly looked at, most of them that looked at falls in those with chemotherapy-induced neuropathy did not capture any data regarding near falls. So that was a contribution of our research to the literature. And our conclusion after looking at this and finding out this information was that possibly increasing ankle strength may reduce fall risk in these women. So we know that you can put your hands on the back of a chair and you can lift up on your toes and back down and up and down low, those calf raises. Well, that actually helps plantar flexion and strengthens it. And perhaps that would prevent falls in the future. So that's what we found in the study that we reported on in seminars.
That's really fascinating. Such important work and great to have this knowledge for women who are experiencing this. I know you also have an NIH funded clinical trial of exercise for CIPN. Would you like to tell us about this trial and any results you found so far?
Yes, so I just described for you the Be Happy study, and this is now we're looking at both the control group and the intervention group. So the women who received the exercise intervention were prescribed to get gait exercises. So you're walking forwards, backwards with your head up and down, side to side, and that's to increase your gait. Balance exercises where you stand on a foam mat or on a firm surface, picking your foot up and down. So we had lots of exercises for gait, balance, and we used resistance bands for lower extremity muscle strength, along with some body weight exercises like lunges, for instance, to increase muscle strength. So so what we found was that I could start with what we didn't find first. So, although we measured nerve conduction, we didn't find any significant differences between the two groups. So, nerve conduction didn't significantly change even with the intervention, nor did muscle strength, neuropathy symptoms, or quality of life. What we did find were very big changes in gait and balance. So, the control group spent let me just say, let me start by saying in the beginning, when we measure everybody at baseline in gait and balance, especially in gait, we found that both the women assigned to the control group and the intervention group all had slower gait. They spent more time on 2 feet. Now, when you're walking, at some point you have your foot down, you pick your foot up, you put it down again. You're in when the process of picking up your foot and putting it down again is called the swing phase of gait. So they had a slower swing. They spent more time on 2 feet than on 1 foot. Okay. So, and had by virtue of that, a shorter stride and a slower gait. So that was true for both groups at the start of the study. By the time the study was done, we found that the control group spent more time, what we call on double support, on 2 feet, as opposed to the intervention group. The intervention group was able to spend more time on a single limb, and they spent more time in the swing phase. They had a longer stride length. They had a quicker cadence, which is the number of steps per minute. So they significantly improved their gait with our intervention, as opposed to the control group. The control group also had more variability in their gait, and that means that they had a more unstable gait over time when we compare both groups together. The exercise or intervention also improved balance in the intervention group as opposed to the control group. The control group had a lower balance score as compared to the intervention group. I will say that BMI influences this. So for both groups, the higher your BMI was, the more poor balance you had. So, but in the intervention group, once they were finished with the exercises over 16 weeks, they significantly increased their balance over time. So when you increase your balance, when you improve your gait, your likelihood of falling is significantly lessened, and that just makes sense, right? So, most of our findings were in this area. Gait had been poorly characterized in this population. As I said, we use very sophisticated analysis of gait, and I think this is a huge contribution to the literature for being able to know how women come into chemotherapy and what happens to them afterwards, and how we can improve their gait and balance over time so that they could function better in their life and prevent falls.
Wonderful. It's great to hear about these results as well. And like you said, so useful for preventing falls.
Mhm.
One additional question I thought of as we were talking just now. I know we've done a couple interviews recently about the challenge trial that was presented at ASCO. And it studied exercise interventions for colon cancer, I believe, and had a very significant result.
Mhm.
Are you familiar with this trial? And do you have any thoughts about it, about breast cancer?
Well, I think they have the same issues because the drugs you get for colon cancer are often neurotoxic as well. So it's great to hear those results and, really, again, another contribution to the literature. There's many ways to do exercise. I think what we need to do is continue to provide rehabilitation strategies for people who are undergoing cancer therapies. Cancer is a chronic disease now, and our treatments, whether they're for cure or control, leave patients with significant side effects or adverse effects. Um, and that we focus more on rehabilitation to increase quality of life because extending life isn't good enough. While we extend life with newer and better therapies, we have to be able to have people have a good life. So longevity alone isn't enough. It's being rehabilitated to be able to perform your activities of daily living where you are independent and have less symptoms is an important contribution.
Absolutely. That segues a little bit into my last question, which is any parting thoughts you have for World Breast Cancer Research Day? Anything you'd like to share about how far the field has come and reasons for why we should have optimism with this ongoing research?
I think exactly what I just said, really. My optimism stems from the fact that we're moving away from, just pharmacologic agents to cure control, which are terribly important, but moving towards more a lifestyle, behavioral science perspective where we're able to help people maximize their quality of life over time. And I think that's an important contribution as we go forward and focusing on that along with our life extending therapies. So I have great hope for our new targeted therapies that have less side effects, and I have great hope for our ability to rehabilitate our cancer patient population as they go through those toxic therapies.
Absolutely. Well, fantastic. Thank you so much, Connie, for coming on today to tell us all about this research and how far the field of breast cancer research has come. And we're very appreciative of all the work that you and your colleagues have done to help improve quality of life and keep moving the field forward. And lots of reason to have hope for the future. So thank you again.
Thank you, and it was my pleasure, and hope to see you again soon.
Absolutely.
Bye bye.